Well, this lecture covering cardiac function will actually be the first half of Chapter 13, and a subsequent lecture will cover the second half of Chapter 13. First of all, we need to just do a brief review of the important aspects of the anatomy of the heart. I've taken this diagram from your textbook, and the subsequent slide, this diagram, comes from a different textbook, but this one shows blood flow through it. So start out with looking at the anatomy of the heart, and then we'll come back to the blood flow diagram. So first of all, of course, the heart consists of four chambers, that is two atria. We have the right atrium here and the left atrium in this position. We have the right ventricle here and the left ventricle here. And, excuse me, we have several valves that are important. The right AV, or also called tricuspid valve, the aortic semilunar valve, and the left AV, or also called the bicuspid or mitral valve, as well as the pulmonary semilunar valve. Now, these valves are important, as shown in this next diagram, because they control blood flow through the heart. So as we have blood returning from the body, coming through the veins, converges here, of course, in the right atrium. And then the blood will flow into the right ventricle. And that, of course, can only happen when the right AV, that is atrioventricular valve, or the tricuspid valve, opens. That, of course, will happen when the pressure inside the right atrium goes up enough to push blood down into the right ventricle. And then blood cannot flow backwards into the right atrium when the right ventricle closes, because that pressure is going to build pressure up on this valve. I'm trying to show that here with arrows. That will cause this valve to close, stopping blood from flowing backwards. So we will not have blood flow backwards because of the function of these valves. Then, of course, as the right ventricle is contracting, the pressure will push open the right pulmonary semilunar valve, sending blood to the lungs, where, of course, it'll go participate in exchange, become oxygenated, and then will return to the left atrium, coming in here, and as the left atrium contracts, it pushes blood through the AV valve into the left ventricle. And of course, when the left ventricle contracts, that is going to push pressure against this valve, causing it to close, but the blood will be allowed to go up through the aortic semilunar valve, which in this particular diagram is hidden behind the forepart of the picture. So the unidirectional blood flow here is due to the action of these valves. And of course, there can be problems where these valves can become so-called leaky, and in which case we can have some problem in their complete control of blood flow. So I've been emphasizing this point already. The valves and their main function is the unidirectional blood flow. So the pressure within each chamber of the heart varies within the cardiac cycle. And we'll be going through this in some detail in what's called the Wiggers diagram in the second lecture, second half of Chapter 13. But it's the pressure differences driving the blood flow. So I'm going to switch to black ink here, just because it's going to show up a little bit better. But blood will flow from the right atrium into the right ventricle when the atrium contracts, and it does start its contraction before the ventricle starts contracting. So, of course, this builds up pressure within the right atrium, pushes blood down into the right ventricle, and as the right ventricle starts to contract, This is going to cause some compression of the blood in the chamber, and it's going to cause back pressure, which is going to push these leaflets on this valve closed. The valve cannot actually flow backwards up into the right atrium because of these little connections, these little ligaments down here that are actually helping to anchor the edge of the valve to the heart muscle itself. But it is the pressure difference between the right atrium and the right ventricle that moves blood down into the right ventricle. And as pressure builds up in the right ventricle, it not only closes the valve itself, but sends blood out to the lungs. And then, of course, that helps to push blood through the lungs, coming back into the left ventricle, which when it contracts, is going to pressurize the blood, helping to push it into the left ventricle. As the left ventricle contracts, it's again going to close the valve and propel the blood out into the aorta. So it's the pressure difference between the different compartments, chambers of the heart, that is driving blood flow. And of course, it's moving from high pressure to low pressure. The normal direction of blood flow is from the atria into the ventricles and from the ventricles into the arteries. Now, it's important that you realize that the two atria contract at the same time, and that they start to contract a few fractions of a second before the two ventricles contract, which also contract at the same time. So in my discussion of blood flow, it sort of gives the impression that blood is moving sequentially one step to the next. It is, but not because of a sequence of contractions in terms of the four chambers contracting independently. And it is the valves that are preventing the backward flow of blood, preventing the flow of blood from one chamber backwards into the other one. All valves open passively based upon the pressure gradient. So each of these valves opens when the pressure on one side exceeds the pressure on the other, when atrial pressure exceeds ventricular pressure. Or in the case of the valves leading to the lungs, it is when, of course, the ventricular pressure exceeds the pressure within the pulmonary artery and then pushes that valve open. But again, the really important thing here is that all valves open passively, and it's the pressure gradient across the valves that makes them open. So again, talk about the names of these. The atrioventricular valves, which is where the AV comes from in the name. The right atrioventricular valve, or AV valve, is also called the tricuspid valve because it actually has three components to it. It does not show well in this diagram. One of them, actually this part has been cut away, but there are three leaflets, hence the tricuspid. The left AV valve is a bicuspid because it has two leaflets to it. It's also called the mitral valve. And I referred to these papillary muscles before. I'll switch over to black ink here. The papillary muscles and the chordae tendineae, these little projections here are the papillary muscle. And the little filaments between the leaflets of the valve and these papillary muscles are what we call the chordae tendineae. So I referred to these without using their name in a previous slide. It is the combined function of the papillary muscles and the chordae tendineae that keep the AV valves from everting, that is, from pushing backward into the atrium when the ventricle contracts. And then the two semilunar valves, that is the aortic valve and the pulmonary valve. Now, in terms of the AV valve action, as blood pressure in the right atrium increases. Now, this pressure is due in part just to blood being pulled back into the right atrium through the vena cava, both superior and inferior vena cava. And then, to a certain degree, there's some gravity helping to pull blood down into the right ventricle. But a lot of that blood is going to move in once the right atrium contracts. Of course, it's going to build up pressure within this cavity. That pressure is going to open up the AV valve even more, pushing most of the blood that's in the atrium into in this case, the right ventricle. Then as the right ventricle contracts, this of course builds up pressure within the ventricular chamber itself. But this is shown by these little black arrows here. I've tried to demonstrate these before. These are vectors of pressure, as is the pressure is building up here in the right ventricle. That pressure is pushing the leaflets of the valves closed. So to go back over to this other side, is pushing against these leaflets of the valves, causing them to close up. And of course, as I said, the chordae tendineae are anchoring the leaflets of the valve so that they cannot actually, the two leaflets of the valve cannot actually push backwards up into the atrium and cause a leak. In the semilunar valve, the closing works a little differently. First of all, again, we have pressure within the ventricle building up, pushing blood through the semilunar valves, either into the atrium or into the pulmonary artery. But keep in mind, both the atrium and the pulmonary artery have a certain amount of elasticity to them. So they have a certain amount of elastic recoil. And as the blood pushes in, of course, it's pushing this valve open. But once the blood has pushed through and stopped pushing, there is a certain amount of back pressure due to this elastic recoil of either the aorta or pulmonary artery that is pushing these two leaflets together and actually causing them to press against each other right here at the point where they would open. And it is that pressure that is actually helping to squeeze those two leaflets together and act as a seal. And that's what stops them from pushing backwards into the ventricle. Keep in mind also that the pressure within either the pulmonary artery or the aorta, it is generally not going to be greater than the ventricular pressure, in which case it's going to also apply less of a backward pressure. As I say generally, at times the pressures can exceed those within the ventricles, but not by a great deal. Let's take a look at the blood vessels. First of all, of course, we have the heart, giving rise to arteries, giving rise to arterioles, which give rise to capillaries. The blood in the capillaries then drains into the venules, which then drains into the veins, and of course the veins then return the blood to the heart. So there is a circuit of blood flow. Arteries are relatively large and have many branches. Their main function is to conduct blood away from the heart. The arterioles are small branching vessels, and they have high resistance, so that they actually produce the resistance to blood flow. This gets important when we talk about blood pressure. Capillaries are the site of exchange between the blood and the tissue. The venules are small converging vessels. They collect the blood from the capillaries and return it back to the veins, which then also converge and conduct the blood back to the heart. It is a closed system. That is, it has a constant blood volume. I say normally. Of course, if somebody has a bad cut and is hemorrhaging, it's not a closed system. But in most cases, it is a closed system. And the path of blood, of course, follows this diagram that I had in this particular slide. But we'll go through it here as well in this diagram because it raises an important point. We actually have two circuits that run in parallel. We have the pulmonary circuit, and we have the systemic circuit. And I say in parallel because as the right ventricle is contracting, pushing blood into the lungs, at the same time, the left ventricle is contracting, pushing blood into the systemic circulation. So, of course, each of these is functioning at the same time. This also means that at the very same time where you have gas exchange occurring here in the lungs, you also have gas exchange occurring out here in the peripheral tissues. It also means that this one circuit can be regulated in isolation from the pulmonary circuit, can be regulated in isolation from the systemic circuit. And we're going to be talking about this idea of parallel pathways of blood and regulation in the next slide. So we talk about parallel flow. Now, we're not talking about the flow on this side being in parallel to this side. That is not what we're talking about. We're talking about the blood flow going to the brain being a circuit that parallels the blood flow that's going to the heart muscle itself, which exist in parallel to that through the GI tract, etc., as well as in parallel to the blood flow going to the lungs. Because of this, we can alter blood flow, let's say, to the brain, separate from the alteration of blood flow to the kidney, or to the skeletal muscles, or to the skin. So it's the fact that these vascular beds parallel each other. If you think about these as parallel lines coming through here, that allows you to independently regulate each and every one of what we call these capillary beds or these circulatory beds. At rest, we have a fair amount of blood going to skeletal muscle, the kidneys, the GI tract, and the brain. The heart itself receives a small amount of blood. This, of course, is blood flow to the heart muscle, not the blood flow through the heart, which, of course, is what's pumping it everywhere else. The skin receives fairly little blood flow. All other organs together, fairly little blood flow. Look what happens during exercise. The small amount here, the skeletal muscle blood flow, which was about 1 liter per minute, now becomes about 20 liters per minute. Now keep in mind that the total cardiac output is about 25 liters per minute. So the skeletal muscle receiving about 80% of the total blood flow during intense exercise. Now, this can happen, again, because of the idea of parallel blood flow, that while the skeletal muscle down here is getting a lot more blood during exercise, it's because less blood is going to these other organs, less blood going to the liver, the gastrointestinal tract, going to the skeleton. So it is by constricting blood vessels, taking blood to, let's say, the GI tract, that will then cause more blood pressure to get the blood flow going more to where it's needed, in this case, the skeletal muscle. This can only happen if you have this parallel flow, which is allowing each of these, the blood flow to each of these organs to be regulated uniquely to the needs of that organ. I've mentioned a couple times blood flow to the heart muscle. Of course, we're referring to the coronary circulation. That is the blood flowing through these blood vessels that is supplying the blood flow to the heart muscle itself. This is not the same thing as the amount of blood that's actually traveling through the heart itself as it's pumping blood through the systemic or pulmonary circulation. It is also in parallel with the other organs in the systemic circuit. So if we go back here, this diagram, you see here where it says heart. This is the coronary vessels we're talking about. Coronary arteries. So the blood flowing through these vessels is, of course, nourishing the heart muscle itself. And the blood in the chambers of the heart, that is ventricles and aorta, does not supply nutrients to the cardiac cells. It is the coronary circulation that does that. Heart also has its own set of capillaries. While we're showing the coronary arteries here, these arteries obviously are eventually going to end in arterioles and in capillaries, and then of course the capillaries will drain into venules and back into veins. The coronary capillaries are supplied by the coronary arteries, the left and right, which arise from the aorta. One thing to keep in mind is that the contraction of the myocardium, that is the heart muscle itself, compresses these coronary vessels. So when the heart contracts, if it has to contract more forcefully, such as during intense exercise, it does apply some compression of these vessels along the heart, which is one reason that heart attacks can be produced during intense exercise. Now let's look at some of the properties of cardiac muscle. We didn't talk about this in the chapter on muscle physiology. We deferred it to this point. First of all, the cells in cardiac muscle are smaller than those of skeletal muscle, which of course means that generally they're going to generate less force because they're smaller. They demonstrate branching, that an individual muscle cell can branch into two other muscle cells, which of course does not occur in in skeletal muscle. Striations are evident, so cardiac muscle is striated muscle, but it's still not skeletal muscle because of these other differences. It contains what are called intercalated discs. Now this is shown diagrammatically here. This in an electron micrograph shows up as a sort of a dark zone, and it's called an intercalated disc. The intercalated discs consist of two things: gap junctions, which are basically electrical synapses. In a gap junction, you have these pores that allow ions to flow directly from the cytoplasm of one cell into the next. So these are going to allow the heart to contract as a unit, because as soon as one cardiac cell starts to depolarize, it is going to depolarize its neighboring cells. And because the cells demonstrate branching, once one cell starts to depolarize, all of the other cells will depolarize very quickly afterwards. Also consist of what are called desmosomes. And desmosomes are protein structural units that resist stress, so that these actually help to hold these two heart muscle cells together. They resist physical stress during the contraction of the muscle, helping to keep the two cells anchored together. The atria and the ventricles are separate units. So the atria will contract as a unit and the ventricles will contract as a unit. The heart is highly aerobic. It uses a great deal of oxygen. So of course this is going to affect the energy supply that it can use as well. It can have no cell division after infancy. The growth is purely by hypertrophy. So you can get cells getting larger, but you can't get new cells. Excuse me. And within the heart, 99% of the cells are contractile. That is, they are involved in pumping the blood, whereas 1% of them are what we call autorhythmic cells. These are the cells that set the electrical pace. That is, they set the heart rate. They conduct the electrical discharge through the heart muscle that is responsible for the EKG. So most of the heart is mechanical tissue, and a small amount of it is electrical tissue. So the function of cardiac muscle. Now in this diagram, what we're actually showing is the sequence of events in the cardiac cycle. And this is something you're going to be seeing over and over again in this chapter. First of all, we have what we call rhythmic contraction. That is, that the contraction itself, which we call systole, followed by relaxation, which we call diastole. Notice in both of these cases, the E is a long E. So we have systole, which is contraction, followed by diastole, which is relaxation. We have atrial systole preceding ventricular systole, and then atrial diastole starting before ventricular diastole. And then we repeat the atrial systole again. So this rhythmic fluctuation between relaxation and contraction that generates the pumping action of the heart. The contraction pushes blood out of the heart into the vasculature. So when the ventricles contract, it pushes blood out into either the pulmonary vasculature or the systemic vasculature. And the relaxation allows the heart muscle to fill again. So after we have ventricular contraction or systole, the ventricle relaxes, the atria relax, and blood is going to start flowing back in, of course, first of all, into the atria and then into the ventricles. So blood flowing into the atria, then into the ventricles. Atrial contraction, pushing more blood into the ventricles. Ventricular contraction starting. In this case, we haven't generated enough pressure in the ventricles to push blood through the valves yet. And once we do generate enough pressure, then, of course, blood starts leaving the ventricles, going into either pulmonary or systemic circuit. Excuse me. So the heartbeat, or that is the contraction that we're referring to, is a wave of contraction traveling through the cardiac muscle. It is preceded by a wave of depolarization. The atria contract as a unit, as I said before, as do the ventricles. Let me go back to the previous diagram. That means, and I'll switch over to black ink here, that basically the two atria, draw a line here, think about it as the top of the heart versus the bottom of the heart. The two atria will contract at the same time. This precedes the contraction of the ventricles, which is actually beginning down here. And it is the contraction of the atria that helps to propel blood down into the ventricle, basically priming the pump, if you will. So when the atria contract, the ventricles are not contracted. The atria are contracting here, but the ventricles are relaxed. Then the atria will now be starting relaxation at the same time that the ventricles are starting their contraction. And when the ventricles are fully contracting here, the atria are actually fully relaxed. So when you hear the heart sound, the lub-dub, the lub is when the atria are contracting, the dub, the deeper sound, is when the ventricles are contracting. So we have this wave of contraction we've referred to before. And as I said, the atrial contraction precedes the ventricular contraction. It overlaps a little bit of time, but the beginning of the atrial contraction precedes the beginning of the ventricular contraction. I urge you to visit this link. It actually shows an animation that shows a very good job of showing how the chambers of the heart go through their contraction, as well as it's going to, this diagram, this animation, is also going to superimpose the electrical with the mechanical activity. It's something I will be using in lecture, but I'm not going to in this recorded lecture. The electrical activity of the heart. As I said, first of all, 1% of the heart cells are autorhythmic cells. Autorhythmicity means the ability to generate their own rhythm. So these cells basically are pacemaker cells. Although not all of the autorhythmic cells are pacemakers. Some of them are. The rest of them act as an electrical conduction system from the pacemakers out to the contractile cells. And these cells I'm referring to are part of what we call the conduction system. These provide an anatomical pathway for spreading the excitation or the depolarization throughout the heart. It initiates with what we call the pacemaker cells. These spontaneously depolarize, and they generate action potentials. And they are going to coordinate and provide the rhythm for the entire heart. These pacemaker cells are located in the SA node and the AV node. The SA node, of course, is the sinoatrial node, and it's where the main pacemaker of the heart is. These are the pacemaker cells that generally control the heart rate. There is a subsidiary set of cells in the AV node that have a naturally occurring rate that's a little bit slower than those in the SA node. Therefore, the SA node works as a primary pacemaker, and the AV node acts as a secondary pacemaker. If damage is done to the SA node, it is possible that the AV node pacemaker cells could take over. Then, going back to the idea of this conduction system, we have our pacemaker cells initiating the depolarization, but we need these conduction fibers, that is specialized cells in the heart that are actually working very much like the axons do in neurons, that they rapidly conduct action potentials initiated by the pacemaker cells into the rest of the myocardium. Their conduction velocity is about 4 meters per second, whereas ordinary muscle fibers have about 1/10 of that rate. These are referred to as the internodal pathways. They exist between these two nodes here. The bundle of His and the Purkinje fibers. Now we're going to show these in a diagram coming up. And this diagram here. So we have the, switch colors, the SA node, the AV node. In between these arrows indicate what are called the internodal pathways. Now these are not anatomically distinct the way the rest of the electrical conduction system is. This is just that basically depolarization moves through pathways of low electrical resistance from the SA node to the AV node. But once you get to the AV node, these are distinct anatomical specialized cells that we call the bundle of His, as well as Purkinje fibers. So the bundle of His here, and the Purkinje fibers, which are the terminations of these fibers coming out of the electrical conduction fibers coming out of the bundle of His. The way this works, we'll switch back to this previous diagram, is that if this is the SA node, keep in mind we have these gap junctions here between cells. So cells in the SA node depolarize. That depolarization moves rapidly down through in two ways. It goes down through this electrical conduction system shown in yellow here. So have the depolarization moving here, traveling down through, gets to the AV node, and then we have our very rapid conduction down through the bundle of His and the Purkinje fibers. As well as between the myocardial cells themselves. So even the contractile cells, once the depolarization invades the contractile cell, because of these gap junctions, the depolarization is going to move from one cell to the next and rapidly disperse that depolarization that was coming down through the electrical conduction system. Now, these internodal pathways that I've referred to a couple times here, they're important. If you keep in mind the fact that the atria contract at the same time, and that they initiate this contraction before the contraction of the ventricles begins. This is because we have these internodal pathways that are diffusely spreading the depolarization throughout the tissue of both atria, but they are not anatomically distinct the way the bundle of His is, the Purkinje fibers. So there's and they do not conduct as rapidly because they're not specialized electrical cells. They do not carry the action potential or depolarization as rapidly from the SA node to the AV node. So that allows the ventricles to remain non-depolarized, that is not starting to contract yet, until the atria have more or less finished the second half, at least, of their contractile cycle, pushing blood down into the ventricles. If you had both atria and ventricles contracting at the same time, it would be impossible for blood to move in one direction. So it is this delay due to these internodal pathways that allows the atria to contract as a unit before the ventricles start to contract. But once that depolarization reaches the AV node, then that depolarization very rapidly moves throughout this electrical conduction system, depolarizing about all of the ventricular cells at about the same time, causing them to contract, again, contracting as a unit, but at a fraction of a second after the initiation of the atrial contraction. So the pathway of depolarization, I've shown it anatomically in this diagram. We're going to go through it step by step in this next diagram. So we have, first of all, this is during diastole here. The heart is relaxed. Then we have the initiation of the pacemaker potential here in the SA node, and this starts sending a wave of depolarization through the atria, as shown here by this tan shading. And because it takes a while for that depolarization to depolarize the AV node, we now have the atria contracting at the same time. Then, just about the time the atria finish contraction, or approaching the conclusion of the contraction, the SA node and the bundle of His depolarizes. And then the depolarization continues through into the Purkinje fibers, at this point depolarizing all of the ventricular cells almost simultaneously, causing them to contract. And then we go through a repolarization phase before we approach full diastole. Now, this pathway of depolarization diagram will be important when we get into part 2 of chapter 13, when we talk about the EKG. So the spread of excitation, and this pretty much need to go back and forth between this previous slide here showing it anatomically and the verbal version here, but you have the interatrial pathway, that is the SA node and the two atria, that the conduction here is very rapid, and it's simultaneous contraction of both the right and atria together. And at the same time, we have conduction through the internodal pathway, that is, between the SA node and the AV node. This is, of course, in part, some of the same tissue we're talking about in our interatrial pathway. Once we've stimulated the AV node, first of all, it's the only pathway from the atria into the ventricles, which means if damage occurs here, if damage occurs in the AV node, let me change color, damage occurs here in the AV node, it's going to be very difficult for this depolarization that initiated up here in the atria to spread down into the ventricles, because the AV node acts like a funnel, conducting that excitation from the atria to the ventricles. So the AV node is very important. It's the only pathway, electrical pathway, between the atria and the ventricles. And there is what we call an AV delay. It actually slows the conduction by about 1/10 of a second. Now this is also, this and the fact that we don't have a distinct pathway up here in the atria, these two things together allow this delay that is going to allow the atria to contract before the ventricles contract. So as I said, this allows the atria to contract before the ventricles contract, pushing more blood into the ventricles. This is important. It's what we will call the Frank-Starling law of the heart. That is the stretching of the ventricular muscle by pushing blood in from the atria that will actually give us greater degree of ventricular contraction. We'll talk about that later. So we have the atria contracting before the ventricles. Then we're going to have ventricular excitation as the electrical discharge is moving down from the AV node into the ventricles, down through the bundle of His, up through the Purkinje fibers. We say up because basically the Purkinje fibers are these fibers that are originating at the, change color, originating here at the bottom of the cardiac septum and moving up the outer wall of the heart. So the depolarization spreading up the Purkinje fibers, and then the Purkinje fibers are going to contract ventricular muscle, contractile cells, and the ventricular cells are going to contract from the apex of the heart up. That is, that the contraction starts here in the apex and works its way up toward the top of the heart. And of course, that's the direction that the blood is going to be flowing, going out of the heart. So let's talk a little bit more about the autorhythmic cells. As I said before, these are the cells that can spontaneously depolarize. So we have the SA node, which basically functions as the main pacemaker of the heart. That is because these cells depolarize spontaneously at about 70 to 80 action potentials per minute. Whereas in the AV node, they depolarize more slowly. So cells in the SA node are always depolarizing sooner than the cells in the AV node, which is why the SA node acts as the primary pacemaker. Then we have the bundle of His. These cells have an even slower conduction velocity, or I'm sorry, not conduction velocity, but spontaneous rate of depolarization. So they are driven, of course, by the AV node, which is faster, which is driven in turn by the SA node, which depolarizes faster yet. And the bundle of His and Purkinje fibers have roughly the same rate of pacemaker potential. So one important point from this is that the faster depolarizing cells control the other ones. Those cells that spontaneously fire action potentials at the most rapid rate are going to be the primary control of the rate, and everything else is going to follow. The fastest cells are going to be the ones that act as a pacemaker. They're going to set the rate for the rest of the heart. Now with that, suppose something happens that causes damage to the SA node. Well, then the AV node will take over. So for this reason, we call it a secondary pacemaker, because it can still drive the heart at a slower rate, but it will continue to drive the heart. It could mean that there is a poor coordination between atrial contraction and ventricular contraction. Now, the pacemakers control the heartbeat by operating on ion channels. Autorhythmic cells have what we call pacemaker potentials. And this is what we're going to be looking at in this diagram, is how these pacemaker potentials in the pacemaker cells, that is the specialized autorhythmic cells. In this case, we're emphasizing, of course, in the SA node because that's where the main pacemakers are. There are a variety of types of channels, what are called funny channels, abbreviated as IF. There are T-type calcium channels, L-type calcium channels, and L-type calcium channels affect a couple of different ionic conductances. So let's take a look at these now. These funny channels, and they're named that because they operate in a peculiar way that hadn't been discovered before, so that they call them funny channels. These are responsible for this slow depolarization, what's called the pacemaker potential here in this diagram. That is this little purple segment. In fact, on the lower half, I have them numbered. Phase 1. Now, there's lots of sodium moving in during this time and some potassium moving out, which is why this potential goes up slowly rather than up rapidly, the way you would expect if you have a lot of sodium coming in, because you've got some potassium outflow or efflux that's offsetting it. But this is going to reach a threshold point, just like we have in neurons. That this pacemaker potential due to the funny channels is going to reach threshold, at which time it's going to activate the T-type calcium channels. That's shown here at the late part of this pacemaker potential, phase 2. The T-type, called T-type because it's transient or brief. The T-type calcium channel begins to open during this segment, and the funny channels close. So what happens, of course, funny channels close, so we stop having our sodium coming in, the potassium going out, and some calcium comes in. Sodium stops coming in. Now, some calcium coming in, that's because of this transient nature of this calcium channel. So that's occurring here. What it's helping to do is to sort of ramp up the effect of the funny channel, if you will. This then is going to approach what looks like a regular action potential that we saw when we looked at the neurons. This is due to the L-type calcium channel, L for large, because the conductance, that is the amount of flow of ions through these channels, is large. So a lot of calcium is going to come in through the L-type calcium channel. And again, this is phase 3 that we're showing here. This is going to cause a large, rapid depolarization. And then the L-type calcium channels start to close. I don't believe at this point it's known if these are inactivation gates, but it's something like what we saw in the neurons with inactivation gates, that the calcium flow stops and then potassium channels open. So does potassium efflux once again, that is repolarizing the membrane, just as we saw in the action potentials in neurons. So now this is the action potentials in autorhythmic cells. Keep in mind, these are specialized cells, and they're specialized to first of all depolarize spontaneously, as well as to have a very rapid conduction of their action potential. The contractile cells are, of course, specialized to contract, not to conduct action potentials. So they have a very different shape to their action potential, and the phasing is different, as well as the ionic conductance is responsible for each of these. So first of all, I'd like to point out that it's a little bit counterintuitive, but our baseline is not phase 0, it's phase 4. The initial depolarization is called phase 0, and it is increased permeability to sodium. So in this case, much more like a neuronal action potential, that this is due to sodium. Keep in mind, back here on our pacemaker cells, the rapid depolarization was due to calcium. So a major difference there between these two cell types. Then, once we reach the peak of depolarization, there is a slight decline here. This is a decreased permeability to sodium, and it's called phase 1. It's very brief. Then we have this long shoulder that basically just maintains this same downward slope that was set up at the conclusion of phase 1. This is increased permeability to calcium, and a decreased permeability to potassium. What's happening is that this calcium coming in is producing this duration of this action potential, this what's called the plateau phase. The plateau and phase 2 go hand in hand. Then during phase 3 again, which is repolarization, we have increased permeability to potassium. No surprise there because that's a theme we keep seeing. And a decreased permeability to calcium, which makes sense. If we're repolarizing the membrane here, if potassium is causing a repolarization, then we do not want to continue to have higher permeability to calcium, which was what gave us our shoulder here. We would want to terminate that. So decreased permeability to calcium as well as an increased permeability to potassium, leading to phase 3, that is the repolarization. And then phase 4 is the resting membrane potential, which of course will persist until another pacemaker potential comes into these myocardial cells, causing them to depolarize. So just as in skeletal muscle, we talked about excitation, contraction, coupling. We have to do that in cardiac muscle as well. And these two diagrams, this graphic diagram and the text diagram before it, go hand in hand. Let me catch up on my notes here. All right. So first of all, we have the depolarization of cardiac contractile cell to threshold. Going back here, depolarization to threshold in a contractile cell. That's going to be causing phase 0 to occur. That's what we're referring to here. This is going to open calcium channels in the plasma membrane of the contractile cell. So let me jump ahead to this diagram. So we have our action potential coming down the membrane of the contractile cell. It's going to open these voltage-gated calcium channels. And then the action potential is going to travel down the T-tubules, that is transverse tubule. That's what we saw in skeletal muscle. So the action potential is going to travel down the T-tubule, down the membrane of the T-tubule. And then we're going to have calcium-induced calcium release. Now we talked about that before with the calcium channels in skeletal muscle, that once you depolarize the T-tubule, that you have calcium release, that it then itself also initiates further calcium release. In the cardiac muscle, it's a major factor is this calcium-induced calcium release, and which are also going to be helping to perpetuate the action potential traveling down through the T-tubule. The calcium is going to bind to troponin, causing a shift in the tropomyosin, just as we saw in skeletal muscle, exposing binding sites for myosin on the actin, and then allowing the cross-bridge cycle to occur. So these steps in excitation, contraction, coupling in cardiac muscle are pretty much the same as we saw in the skeletal muscle. Relaxation, however, is different. Basically, there's removal of calcium from the cytosol. There is this circa that we talked about before, that is the calcium ATPase in the sarcoplasmic reticulum. So this would be this pump shown right here. This is the circa. There's also a calcium ATPase in the plasma membrane. So that is this pump here. What it's doing is it's active transport, pumping calcium out against its concentration gradient. Of course, whenever you have active transport, it's because it's pumping something against its concentration gradient. Remember, there's about 10,000 times more calcium outside the cell than there is in the intracellular fluid. So that's why we need an active transport pump. There's also what's called a sodium-calcium exchanger in the plasma membrane. Now, the way this works is that there is more sodium outside the cell than there is inside the cell. So sodium coming down its concentration gradient, this is basically what's called facilitated diffusion. Sodium coming down its concentration gradient is causing some of the exchange of calcium. So we have all of these three pumps working together to alter calcium level. That is our circa, the calcium ATPase, and the sodium-calcium exchanger. And then troponin and tropomyosin return to their normal resting position, covering the myosin binding sites. But this is, again, this change in troponin and tropomyosin position is due to these three different calcium pumps where in cardiac muscle, whereas the only one that we saw in skeletal muscle was, of course, the circum.